Good evening, everybody. Um, we have five cases today, and experts for today are Prahlad Prabhu Desai sir from Mumbai, with Rajan sir from Mumbai, and Murli Mohan sir from Narayan Hrudyalaya, Bangalore. Those are our pulmonologist expert. We have got Dr. Vimal Raj as a radiologist expert. Thank you, sir. And Sharda as a pathologist expert. With Mithun will be joining in a while, who will be our rheumatologist expert. We have five cases, two from my side, one from Shobha madam, who is also from Amrita, and then we have got one from Rajan sir and one from AIMS Rishikesh. So as we can see that we have five cases to finish, I will just share my screen and we'll go to the case number one. Yeah. Okay. I hope my screen is visible and it's moving. So this case number one, which I came across last month, she's 63 years old lady from Kottayam, homemaker by occupation. She has diabetes, hypothyroid, GERD with esophagitis. That was a endoscopic diagnosis. That's why I specifically wrote esophagitis. She was treated as obstructive airway disease for last 2 years. Since that time, her complaint started. So she had cough for last 2 years, was treated as obstructive airway disease. She gave history of dust allergy. Now, the when we asked for exposure history, she told that her house is near a brick factory. So she was exposed to those red sand for almost 15-20 years. However, those factory people moved away from their house for last 7 months. But for last 15 years, she was exposed to that particular brick dust. That is what she told, and biomass fuels. Uh, when she came to me, before coming to me itself, that this was a second visit in a 1 month. Before 15 days she was admitted at outside hospital with pneumonia, fever, dry cough with chest shadow. Why I'm telling pneumonia? Because there was a radiological signs, and she also had associated dyspnea. Basically, when she came to me, she was unable to lie down straight because of cough. There were significant dry cough as well as tracheobronchomalacia, quality of cough. There were no joint pain or no CTD stigmata, but she gave history of episodic recurrent fever and myalgia for last 1.5 years, and she is in and out of hospital. When I examined her, she was afebrile, but her saturation was 98, tachycardia, BP was normal. There were fine basal crepitations in the right infrascapular area. She had ESR of 110, and RA factor was negative with uric acid 4.24. This were investigation done outside. This is the ANA profile done here, and I'll ask Mithun to just read the report for you people. If anything significant, Mithun, you feel ESR was high outside as well as I think our also 110, with PMSCL 100 of less than 1 plus, and PMSCL 100 in myositis panel also almost 1 plus. What do you see, Mithun?
Very low titer positivity may not be significant.
Nothing is significant, and yeah.
Only if clinical features like CPK is high, then only, or muscle weakness, then only
No,
consider it as positive.
she had myalgia but no muscle weakness. I specifically asked, is there any problem or not? This was her bronchoscopy. Uh, I believe that before bronchoscopy, I will ask Vimal Raj sir to show the CT, and then maybe it will be better. Why did I do bronchoscopy? Yeah.
Okay. Thank you very much. So this is let me start off with a chest X-ray of this lady. So this was the initial chest X-ray, and where you can see these multi nodular opacities and patchy areas of consolidation in the lungs bilaterally. And then we have the CT of this patient. Let me get that back in the position. Okay. So when we look in the mediastinum, there is nothing much, no significant mediastinal lymphadenopathy or axillary or upper abdominal lymphadenopathy, no pleural or pericardial effusion. When we look at the lung parenchyma, lots of interesting changes. You're seeing these nodules of varying sizes in the lungs. These are randomly distributed but bronchocentric in location, quite central to the bronchi, widespread. And some of these are actually quite large, especially if you see in the left lower lobe here. These are quite large areas of nodular opacities in there. Without any great history, I would have first thought in terms of a atypical infection, like a fungal infection, is something that we really need to consider in here. Organizing pneumonia would be another thing. Doesn't fit very much into neoplastic because this doesn't have a hematogenous spread kind of a pattern. It looks more like a broncho centric distribution of disease. But those would be my differential diagnosis. Atypical infection, need to exclude fungal
Yeah.
etiology, would like to think about organizing pneumonia. Neoplasm would be my third one in there.
Yes. So, as sir rightly said, even I thought only two diagnosis: infection, definitely infection because of some fever which was going and counts were high and all, and fungal infection as well as organizing pneumonia. However, my radiologist insisted for biopsy, telling me that left lower lobe can be bronchoalveolar carcinoma, and that was the reason that I went and did bronchoscopy. And second thing, this was going on for long time, and because 2 years history, so we decided we will go in and did. So
I think can I talk?
yes sir.
Yeah. I think considering the shadows which are there in the both the sides, which are dense consolidations, okay, and some of them are subpleural, which very randomly, it's not really some anatomically one particular segment lobe distributed, with the ESR of 110 and not very high grade fever. It must be a small
Mm-hmm.
fever, which is it looks like to be as a round form of organizing pneumonia, nodular form of
Yeah.
organizing.
Yes.
We don't know the cause for that nodular organizing pneumonia, but probably.
Agreed. But there is a surprise, because
Yeah.
what happened is I also thought that organizing pneumonia can cause weight loss, organizing pneumonia can cause fever, and I was almost this patient. I didn't suspect malignancy, but I did biopsy,
Correct.
and because we found there were some bronchial abnormality also, so we did both biopsy. We did transbronchial lung biopsy and we did bronchial biopsy. And Sharda, if you can throw some
Yes, ma'am.
lights on this.
Yeah. First of all, many thanks for the opportunity, and good evening, everyone. So this is the first picture that I was I was mailed, and this picture was it looks more like an endobronchial biopsy. So this is the airway epithelium, and underlying the airway epithelium, there is a lot of moderate chronic inflammatory infiltrate, and under this cover, I could find few scattered multinucleated giant cells. Of course, there's a lot of hemorrhage above and on the left side. Yeah, next image. And so the first image here, this is showing the alveolated lung parenchyma. And so there is mild thickening of this alveolar septa, and there is chronic inflammatory infiltrate, again, lymphocytes and plasma cells. And along with that, there are focal emphysematous changes in the first image. And so there is mild to moderate chronic interstitial pneumonia in this image, whereas in the prior image, there is chronic bronchiolitis. Yeah, there is chronic bronchiolitis because here there is a airway, and then under that there is the chronic inflammation. And even this picture on the right side, this is again showing the airway epithelium on the top, and then underneath there is this chronic inflammatory infiltrate. Apart from the lymphocytes and plasma cells, which are seen predominantly in this picture, I could find few polymorphs as well. And only in this picture I could find few polymorphs. The rest of the images I found only the lymphocytes and plasma cells, only the chronic inflammatory infiltrate. The next image, madam. Yeah. So the first image, the arrow is pointing to these scattered multinucleated giant cells. And apart from that, on the left, Under this power in this image, I'm still thinking like, can this be a non-necrotizing epithelioid granuloma? Because apart from lymphocytes and plasma cells, I could find few cells which are looking like epithelioid histiocytes. And
Okay.
again, in this the second image, it's showing these multinucleated giant cells, which are mostly of the Langhans Langhans type. And apart from that, there is this chronic inflammatory infiltrate surrounding these multinucleated giant cells.
Yeah. Yeah, that is what. So my diagnosis was organizing pneumonia. That is what I wrote in the pathology slides. And I got a call from my pathology telling that because there was a brick exposure history, she got back to me and told that, are you suspecting hypersensitivity pneumonitis or not? Anyway, that happened afterwards. But what
So,
happened in between is
yeah.
because I was not happy with the diagnosis given by pathologist, I requested my radiologist to go ahead with CT guided biopsy. And that CT scan, if Vimal Raj sir has got, if he can show that.
So in this slides that I'm shared, the pictures, I couldn't find any organizing pneumonia. There is no neoplasm. And so my diagnosis, the first one is again infection. It could be mycobacterial or atypical mycobacterial infection. And I didn't find any fungal organism, and there are no pointers towards fungus. Like, I didn't find large
Yeah,
areas of
neither
necrosis. There is no
microbiology. Yeah,
eosinophils.
yeah,
There
no
is no there.
microbiology.
I
Yeah,
didn't find any fungal hyphae, or I
sure.
couldn't find any eosinophils as well.
Even
And
MTB was negative. We
okay,
did everything. Yeah.
okay, and remote possibility
Dr.
of
Sharda,
I mean,
Yeah.
Dr. Sharda,
yes, sir.
could I ask, would you consider sarcoid or a foreign body granuloma as explaining these pictures? I mean, she's been exposed to a lot of brick dust
Yeah,
inhalation,
hypersensitivity
so I
one.
was
My
wondering.
first differential is infection, and the second one is hypersensitivity pneumonitis. I don't think of sarcoid because the granulomas in sarcoid are very well, they can be distinguished histologically. Very well circumscribed granulomas with the onion skinning and all these things. So I couldn't find these granulomas are very, at least in the picture that I've seen, is a very vague granuloma, epithelioid granuloma, non-necrotizing.
Yeah.
Asmita, I don't have the biopsy CT. I do not have that.
You don't have? Okay,
No,
so
I
what
don't.
happened is when I insisted for doing a biopsy from that, the left lower lobe nodules which were there totally got cleared. So that made me think, but those halo signs or those cavitating pneumonia signs were still present. So we started her on antifungal and we discharged her, thinking that it was infection because so fast the only thing which can get cleared is infection. And within 1 week, she came again with fever. And that time her counts were 27, 28,000 or something. That is why we thought that are we really like I didn't start her on steroids at that point of time, other than the short term steroids which she was given during admission. So we were worried about is she having infection or something else, and I have to give her high end antibiotics. But when multinucleated giant cells came, by the time the biopsy report came, final report came, it was looking like this. So my question to the panel was, like, even though the infection or organizing pneumonia component which got cleared, can it be still HP? Considering her significant exposure to red sand brick factory at home for last 20 years, but stopped for last 7 months. And while her problem has started 1.5 years back, and I just gave her antibiotics, should I give her steroids if it is HP? I was worried because her counts were 25,000 when the next time she came for admission, and I was really worried. I stopped antifungal because she developed LFT derangement, and she improved with antibiotics alone. So antifungal was given only for 1 week. Within 1 week, she became very sick and came back with infective exacerbation. That was a pure infective exacerbation, maybe because of hospital admission or whatever way she developed. Then it got cured. She went home. I have not put her on steroids, and I was just waiting for this discussion. Should we give, by looking, by the time my pathologist called, that even multinucleated giant cell she could find out.
Anything on BAL, Asmita, when you did a
Negative,
BAL?
negative, everything negative, sir. No fungal hyphae also,
And I think,
nothing.
Asmita, we are
And
dealing
Asmita, do you have any
with
sequential CT scans? I mean,
I
following.
have, but let me see. I will pull it. You people go ahead with discussion. I will pull it. Don't worry. Yeah. Okay.
More likely to be inflammatory rather than infection.
Sure, sure. I will
If
show
she
you. I will
receives
show
for
the
1.5
second CT
years, she must
scan.
have received plenty of antibiotics in
Sure,
between.
sure, sure. Yeah, I'll show you the CT scan.
If you want to give a steroid, it should be a small dose of steroid probably should require.
Hmm.
Any
Now,
HP
prednisolone.
serology done, madam?
And
No, I don't do those things here.
Okay.
It's not done in my hospital, and I don't send it outside.
We
This is the
sometimes do it
comparative
in
chest X-rays of two dates. So I have the chest X-rays. This one is from 20th of December, and this one is from 20th of December, the old one, and this is from 8th of January. So about 3-4 weeks difference. So the right lower lobe, if you can see, has cleared a little bit, and the left lower lobe also looks much better between the two scans.
Yeah. If I will just scroll my images. Sir. 1 second.
Have been a viral infection, like peribronchial
So this was the
problems could present in
this.
viral infections like varicella zoster as well.
So you people can see these images, right?
Yes.
Yeah, so this was the left lower lobe. I actually was very persistent that I want biopsy from radiologist. So they did it, and they called me that those things which you wanted me to biopsy from is cleared. You agree, right, Bimal Raj sir?
Yes.
Yeah, so that is what happened. So this was the follow-up CT. On this CT scan, I discharged her, and then she came with infection. After that, I have not repeated CT chest at least I have not repeated.
Right, confusing case. But I think one of the things I would like to consider is a dual pathology. That she came in with an infection on the background of a long-standing red brick dust exposure. With red brick dust exposure, I would think more of a pneumoconiosis than an HP. But we don't know what are the rest of the circumstances which could have provoked an HPR. So I think what you're left with now is one infection, got cleared with her antibiotics, and in the background you have something else, most of which has cleared up is what is probably the respiratory infection.
Yes.
And now you're left with something which is, the differential would be between an HP and a pneumoconiosis. A lot of little nodules. Vimal, would you think that pneumoconiosis would fit this? It's not a typical silicosis, but that's what you when you have red brick, it's basically inorganic substances.
So the problem with these nodules are they are quite solid nodules. They are not tiny nodules. They're quite large nodules, which is little atypical for a pneumoconiosis unless until you start going into PMF, which this is not anywhere in there. So
Yeah.
I would expect these nodules to be much smaller, more ground glassy than this for an HP or a pneumoconiosis.
And Asmit, I would like to know actually what antibiotics you gave because I think I'm not sure whether TB has been adequately excluded because that.
I know TB is excluded, yeah, because I did MTB panel, that is AFB smear, AFB culture, gene expert, even pathologist does those stains. So TB in India and in my hospital, those who know that, like my husband is a HOD of microbiology, and I can say that he's good enough to pick up TB at least. So I know it is not TB because TB I won't miss, believe me. It was not TB because I gave her Magnex and clarithromycin or something in the first visit, then discharged her on voriconazole when she came with additional infection, and that was 29,000 counts. And she presented to ER. That is what made me worrisome. I started her on meropenem. And with meropenem, she improved. Yeah, I didn't give her, like, I know every antibiotic has got some TB coverage, but no, TB does not get cured with so fast. I think Prahlad Prabhu Desai sir will agree with me, right? If it was TB, it won't get cured. Like CT scan response, right, sir?
I think we future you observe for some collagen vascular disease, whether it's coming up or not.
Yes, sir. Yes, sir. So we can observe na, rather than giving steroids. What is the panel saying, right? My decision of not starting steroid, you agree, right?
Yeah, again, I don't think that we should start steroids. My first
Okay.
differential is still it's a infection, and then second is
Yeah.
possibility of organized pneumonia / HP. But I think
So
we
if
should
it
continuously
if it
observe.
comes back,
Yeah.
if it comes
Yeah.
back, we will treat. I also thought like that, let me give a time, maybe 1 or 2 or 3 months and repeat CT scan if I am in doubt, and to start steroids if required. What do you say? Right?
I would agree.
Absolutely, completely agree.
Okay,
Yeah.
okay, okay, okay. Moving to second case. Yeah. So this is also another interesting case. This is from Maldives, and she visited our hospital in 2018 also with the same complaint. Anyway, this time she came because she was admitted at her place, and she was found to have some finding on the X-ray, which that doctor felt that they cannot do anything about, so referred to us. She also gave history of recurrent pneumonia 4 times in last 15 years. She's 69. She told me that she is exposed to birds when I inquired. And you will be surprised that the birds, I will just show you that initially she showed me only two parrots. And then when I asked that, okay, only these two birds cannot cause this much of problem, then she showed me the Pandora's box, and I will just show you those. And she came to me with history of cough, yellow expectoration, and bilateral coarse crepitation, not fine crepitation. She had clubbing also, and shortness of breath associated with wheeze for last 15 years. She is on inhaler with multiple course of antibiotics. So initially she showed me these are the two birds which she has got and some lovebirds at home. But because I admitted her during the course of admission, the daughter got me the pictures of all the birds which she is having at her home. These are all the birds at her home. They actually sell these birds. They do business of these birds, and that lady stays in that house. So these are the birds which she is exposed to, and her saturation is 99, but she had wheeze and crepitation. Clubbing was present. I admitted her. This is her ANA profile and myositis panel. Mithun.
One second, one second. AMA-M2 is basically is a primary biliary cirrhosis antibody,
Mm-hmm.
and is 1+ positive. In this clinical scenario, it is not significant because PBC we don't expect in this patient, no?
Yeah, she doesn't have any LFT problem as such right now. And AMA is particularly that ANA was negative. So if ANA is negative, should we ignore ANA profile? No, not like that, right?
If ANA is negative, you can get positivity in anti-SSA and anti-SSP.
Okay.
Otherwise,
Row
in
and La. Okay.
Rho and
Yeah.
La, that can come
Okay.
as positive.
Okay.
For example, if you suspect Sjogren's strongly, even if ANA screening IFA is negative, you should do a ANA profile. Otherwise, in all practical purposes, if ANA IFA is negative, ANA profile usually comes as negative.
Okay.
And if mild positivity, we can ignore actually.
Sure.
Dr. Mathun, actually about the myositis, that I have seen a lot of myositis antibodies coming when the AN is negative. What is your
Yes,
experience?
yes. Myositis antibodies, most of them are from the cytoplasmic antigens. Therefore, in antinuclear antibodies, ANA profile, you do antibodies against the ANA, what you call, nuclear antibodies. If
Yeah.
cytoplasmic antigen, if antibody against the cytoplasmic antigen is positive, then you get cytoplasmic fluorescence in ANA immunofluorescence, which most of the lab, they report it as negative. If nucleus fluorescence is not there, they report it as negative. And some lab only, they specifically mention there is a cytoplasmic fluorescence is present.
Yeah, the reason we ask this question, Mithun, is some people follow that, okay, I will send ANA by IFA, and if it comes positive, then only I will send ANA profile and myositis panel and all. So this
No,
is for a message that it is not necessary that ANA has to be positive for all CTD, right?
Correct. If you are suspecting a myositis disease, you have to send a myositis profile. You need not depend upon the ANA IFA.
Yeah, that is.
And ANA IFA, I told you, no, only in Sjogren's disease, you have to, if otherwise in all practical purposes, if ANA IFA is negative, the ANA profile also comes as negative.
Negative only, yeah. And this is also not significant. By now, I can say that there are multiple positive. So this is not significant, right, Mithun?
Yes, correct.
Yeah, okay. So this was the last patient. I didn't do PFT because she was having infection and I had a doubt. This patient in the OPD I could manage, and her FE1, FVC, even though obstructive panel, this pattern, there was a low DLCO and low KCO. She didn't have much desaturation, but she did walk also. She walked only 120 meters and she stopped because of uncontrolled dyspnea. We did a CT scan for her, and I will give it to Vimal Raj.
Okay, so this is a CT, and what we can see here, a couple of things. The esophagus is distended along the entire length. You can see the esophagus is quite distended. There is fatty deposition in the liver, and what we can see are few prominent lymph nodes. There is mediastinal, subcarinal, and right hilar prominent lymph nodes.
Yes.
When we look into the lung parenchyma, what is very interesting to see is that we are seeing a lot of haziness in the bronchocentric distribution, lots of nodules in the bronchocentric distribution. There is bronchial dilatation in keeping with bronchiectasis, and then segmental collapse and consolidation in the right middle lobe, lingula, and also the anterior segment and posterior segment of the right upper lobe. So a lot of peribronchial nodular changes. All of this is fitting into bronchiectasis with secondary infection inflammation. As we come lower down, this is where we start to see slightly different pattern. You're starting to see some cystic changes towards the periphery of the lungs, which are not typical of bronchial dilatation. And then here we are seeing reticular changes, traction dilatation of bronchi with ground glass opacities, with some mosaicism that we can see. I do not have a expiratory image, but I would imagine there'll be lots and lots of air trapping because there is airway disease anyway in this patient. So there are two things that we are looking at. Definitely there is bronchiectasis, secondary infection, might be even looking at atypical mycobacterial infection in these in these areas. And then there is a background of what looks like an ILD, connective tissue disease slash HP would be something that I'm looking at in these patients. Some of these cystic changes here make me think, could this be a CTD kind of a picture? The pulmonary artery is not dilated, no features of PH that we can see.
Sure. Thank you. So moving on to my patient. So as we can see in the CT scan, there were thick purulent secretions which were coming, which may be like, is it like only bronchiectasis or secondary infection rather than anything? As sir showed, there were huge lymph node at station 7 and station 4R, 4L, 10R, everywhere. Anyway, the largest was on 7 and all lymph node had same characteristics. So I just attempted 7 biopsy, FNAC, nothing else. And I will give it to Sharda for further. We did, this is a ball smear, I think, yeah.
Yeah, this bowel cytology smear, this is basically, I guess, yeah, it's a FAB stained smear. And what I could see is, as it's already written, there are a lot of polymorphs in both the low power and under high power. And occasional, I couldn't make out any occasional, maybe there may be angular macrophages, at least in this image, I'm not able to make out any macrophages. But what I could say is there are a lot of these polymorphs. So what I would like to ask is, are there any, did the pathologist do any special stains on this bowel smears?
No idea. I don't know. Maybe
So,
you know.
So I would have done special stains on this bowel smears.
No, usually we send BAL for microbiology. They do AFB and PAS. Yeah, that is what the special stain, if that is what you meant, that's what they do, AFB, PAS and all.
AFP,
So,
yeah, AFP, PAS and GMS. These are the special
yeah,
stains that
so,
I do usually when there are a lot
yeah,
of
so they do that. Yeah, they do
polymorphs.
that. Yeah.
And this is a lymph node, I guess.
Yeah, this is
And
FNAC.
yes, there are a lot of lymphocytes, lymphoid cells, which are normal component of the lymph node. This is what I could see in this.
Yeah.
And this cell block is also the same, showing the same features. There is some crushing artifact I can see here, and these are all the lymphoid aggregates. Apart from that, I couldn't find any any
Yeah,
other
even
positive
even my
finding.
pathologist also told she doesn't see any
I
granuloma.
didn't
Yeah.
find any granuloma. I didn't
Yeah.
find any malignancy in this.
So lots of inflammatory cells and lymphocyte. That's what she told. Anyway, this patient also we treated with antibiotics. The reason we discussed was, is it only bronchiectasis or is there any ILD? And there was thick purulent secretions, which made me worried about starting her also on steroids, in spite of my suspicion is HP. I sent you two X-rays, na, sir, 2018 and this is 2025. So because there is no significant, I don't have a CT scan of 2018, but there were two X-rays which is not showing significant progression, at least on the X-rays. So should we really treat her as HP or something, or we can just treat her as a bronchiectasis? That was the thing.
So this was the chest X-ray that we can see. This is the recent one, the right side one, and this is the old one. And as you said, there are all these areas of nodularity which is unchanged from before, and the interstitial changes.
Yeah.
And I think there is mild progression, not a major progression between
Yes.
the two scans that we are looking at. So this is nearly 7 years, and for 7 years, it's
Yeah.
not too bad at all.
Yeah. So that is why. So I also felt like, treat her as a bronchiectasis, or should we bother about CTD? Yes, sir. Only Mohan, sir.
Again, Asmita, can I know the microbiology of the
Negative, negative. If anything positive, I'll say it loud.
So, Dr. Ratnapalo, you want to go ahead?
No,
Yes,
he
you do. Please, Dr. Murli, please go ahead.
Yeah. So two things. One is, I think, obviously, as Vimal said, there's bronchiectasis, and that's the major feature. The lack of progression over such a long time makes it unlikely to be, an interstitial lung disease. However, the exposure cannot be ignored completely. And rather than think of HP, I was wondering in this patient, should we be considering, though the microbiology was negative, should we still be working her up actively for a non-tuberculous mycobacterial infection? She's been exposed to birds. Mycobacterium avium intracellulare, as the name implies, is associated with bird exposure because infection seems to be the predominant thing. So I'd be very hesitant to give her steroids. I would watch, look for progression over 3 months to 6 months. And if there is progression, then I could probably consider doing, a repeat biopsy, maybe a VATS biopsy. The other only interesting thing is, as Vimal pointed out, there's a lot of esophageal dilatation. That's a strong pointer towards a CTD. But the CTD is negative. There are no clinical features. I keep that in the back of my mind.
We lost you, sir.
I think, can I talk?
Yeah, yes, sir.
Infection is the predominant thing. Now, whether there is associations.
Not that great, but is it, something that's mycobacterial PCR?
Okay.
So, infection, yes. Now, from where we can get infection, maybe it's a chronic aspiration because of the dilated esophagus. And that may be one of the reason. I don't know, but exposure to this so many birds, which she has, we can get histoplasma and other infections, which probably may remain silent for a long period of time. And it will behave like a chronic bronchiectasis, fibrosis, and all those things can develop because of the this inflammation which is there, which can happen following this chronic exposure to the birds. And we must do some, and it is very difficult to diagnose unless we do the urine for histoplasma antigen or something like that in addition. And obviously, the esophagus has to be investigated. Is there any motility disorder? Is there or not? Because chronic aspirations can give rise to all these features.
Yeah. Rajan, sir.
Histoplasma actually, sir, shows a lot of necrosis in the lung.
Okay.
Okay.
Yeah.
I really don't have anything to add to this. Yeah, I think I would agree with what Murli and Though I missed the last part of what you were saying, Murli. You went off.
PCR
I'm
and
sorry.
also, yeah.
Yeah, I was thinking of non-tuberculous mycobacteria and whether we can do a PCR for non-tuberculous mycobacteria to get a quicker answer. It's not.
So for PCR, you need to have culture positivity. Otherwise, in my
The
hospital,
yield is not
yeah,
great.
yeah, in my
Absolutely.
hospital, we need culture positivity. If it comes positive, I'll send it for that. Yes. Okay.
For speciation.
Yes, yes. Species identification.
Okay.
Yes. Okay. Okay, we'll move on to third case. So no steroids here either. Okay. The third case is from HOD of Pulmonary Medicine, Dr. Shobha Subramaniam from Amrita Hospital only. Madam.
Right. Yeah, I have got a 65-year-old female who has comorbidities of hypertension, diabetes, hypothyroidism, and osteoarthritis. She is a homemaker. And no past history of TB or COVID, exposure to
Firewood.
biomass fuel, no exposure to pets, dogs, birds, etc. Her main complaint is 6 months history of shortness of breath only on exertion, progressing from grade 2 to 3, no seasonal variation, which was associated with dry cough for 4 months. She has been treated as obstructive airways disease. She complained of loss of appetite and loss of weight 5 kg over the last 6 months. There is no suggestion of any joint pains, dryness of mouth, or any photosensitivity to sunlight. Examination, saturation 91% on room air, heart rate of 89, blood pressure okay, but she had clubbing and she had some rashes over the extensor aspect of the forearms and the skin of the fingers was shiny. Respiratory system showed bilateral basal crepitations. That was her chest x-ray, which showed, I think I will leave to Dr. Vimal Raj for discussion on the chest X-ray and CT, but I'll just quickly go through the PFT, which shows ratio is 0.83, that is normal, and FVC is reduced. So moderate restriction, both DLCO and KCO are reduced with slightly reduced alveolar volume. And we did a 6-minute walk test, which showed desaturation from 95 to 89, but she could walk 360 meters with slight breathlessness. Yes.
So this is the CT scan, and what we are basically looking at to start off with, a couple of interesting things, quite the enlarged thyroid lobes bilaterally with focal calcified nodules. There are then these prominent lymph nodes, and the subcarinal lymph node is also quite big. As we go further down, there is a moderate sized hiatus hernia that we can see in this patient. The pulmonary artery is okay. She's got few small nodules in her breast, nothing sinister. And when we look at the lung parenchyma, this is more of an expiratory phase imaging, and you can see there are these bronchocentric ground glass opacities with traction dilatation of bronchi and extensive mosaic attenuation. And as we go down, there are large confluent areas of ground glass opacities with these secondary pulmonary lobule kind of sparing that we can see towards the extreme lung bases in there. The fissures are reasonably clear. I'm not seeing any cysts. I'm not seeing any honeycombing at this stage. There are some areas which may be early stages of honeycombing, but currently nothing, and not seeing much nodules in here. So we are looking at an active phase of disease, two differential diagnoses, HP versus CTD, ILD. Radiologically, I think there are markers which support both. The amount of small airway disease which is associated with this makes me think more of HP, but clinically, I can see the skin changes are pointing more towards CTD, I would imagine. So those would be my top two differential diagnosis here.
I'll show you. I'll show you.
Yeah. We did proceed with the CTD workup. ANA was negative and rheumatoid factor is negative, but myositis profile came back as MI2 beta 16.
Mithun?
Yeah, I'm just looking. MI2 beta, it is a mild positivity. What you expect with MI2 beta is it's a nuclear antigen. You also expect a INA-IFA to be positive because as it is a nuclear antigen. And if it is ANA negative and MI2 is 1 plus, then we have to consider it as a low titer positivity. Not much, if clinical scenarios are very much fitting, like MI2 beta is associated with typical dermatomyositis rashes. If there is no rash, nothing is there, then it may be difficult to give importance to this low titer positivity.
There was rash, na? Madam said.
Yeah, on the forearm.
Rash, if it is typical of dermatomyositis, I think you have photos of those.
No, I don't have.
Okay.
And this SRP positivity very unlikely to be significant. It is usually associated with very aggressive muscle myositis, like necrotizing myositis type clinical manifestation, which is unlikely in this patient.
Okay.
Low titer positivity is always difficult to assess. When you have a typical clinical features, then only you can say this is significant. Otherwise, at least 2 plus should be there. 1 plus can be easily false positives.
Any history of exposures, Shobha, or change of residence?
I could not get any positive history of exposure. Other than biomass fuels, she's not exposed to any other significant things.
And what was her vital capacity?
Vital capacity is 68%, I think.
68% predicted. Yeah.
I'll show that up.
Yeah, I would probably think of, HP here. So the amount of air trapping that you're seeing, and I think it would be good to consider immunomodulation for some time. If you haven't given her, and she's not on anything, right?
I have just started her on steroids.
Yeah. I think I probably see the response to immunomodulation for a couple of months. Yeah, Prahlad, you were saying something.
She's hypertensive diabetes, weight loss of 5 kg. There's a mediastinal subcarinal large lymph node which is there. Okay. I think we need investigations for this. And lung functions are very well preserved. Any ILD will not have this sort of a radiological picture having a very well preserved lung function, I feel. Even 6 minutes walk distance also. Probably we are dealing with some infection, I feel. Okay.
So her lung function is already, vital capacity is already low, no? Prahlad. And
69% of the patient.
60,
I think
68%.
but DLCO was low.
DLCO and DLCO, KCO, both are reduced.
Both are reduced, and
But
she's
the
desaturating
exposure,
to
if you
89.
see, the amount of lung involvement, it's too significantly
So
high.
that's why I thought it was more inflammatory. How sinister is that subcarinal node in your opinion,
It's a
Vimal?
large lymph node, right? 3 centimeter.
Vimal?
It is significant, actually. I'll tell you it's significant in the sense it is compatible with what we are seeing in the lung parenchyma. I don't think it is a TB or neoplasm, if that is the question.
Okay. That is reassuring.
That's what I was also thinking, but I think from what Prahlad is saying is should one stick in? You would get a biopsy done of that node, Prahlad?
Yeah, of course. There may be a dual pathology. I'm not saying that, but lymph node may be a silent thing. If you would give steroids or something like that.
Because of her weight loss, yeah. I guess that's something you may want to talk to her about, Shobha, because of her weight loss.
I will seriously consider that.
Yeah.
Thank you.
because we would be pretty fast on a subcarinal biopsy because Bhavin is very comfortable doing that. We just get it done, talk to the patient, but C65, and obviously if you have tuberculosis sitting there, she's going to get worse if you just
Yeah.
give her
Yeah,
steroids.
she's a
and
diabetic.
She's diabetic hypertensive too. Yeah.
First will be probably a right way to go. Lavage also we can do. We can have a lot of information and also probably biopsy. Maybe we'll talk.
Yeah.
So a bronchial wash with a TBNA or EBUS guided. Yeah.
Yeah.
Hmm.
Yeah.
Hmm.
Yeah.
Yeah, that's
Typically, it all looks like the CTD-ILD versus HP, as everyone has said. Um, I myself, was impressed by what Dr. Shobha said about the skin features. So, which is why I was leaning a little more towards a CTD. In either case, the treatment initially doesn't change anyway. You're going to, put it on steroids, consider whether you need to introduce a immunomodulator. But, I agree with what Dr. Prahlad Desai has said. I think it's important to rule out an infection. One of the other things that you can do, if you've already started on steroids, doesn't matter, but maybe we can consider doing a MAN2 and a quantiferon.
Okay.
More from the point of view of, is there any latent infection anyway? So from that, it would be important to check it out. I think Dr. Prakar has said something like, could it be LAC? Do you want to unmute and tell us?
I don't think does it look like lymphangitis, Vima?
No.
No.
There's not much of septal thickening. There's ground glass opacities. There's no nodularity also, so
Sure,
it doesn't look like it.
The air trapping is very impressive,
Yeah,
so
yeah. Which
So
is why,
I was
Murli, I
just
thought this
wondering,
sort of,
this lymph node can be because of HP also, na, sir? Sometimes.
yes, it could be. It could
absolutely,
be.
absolutely.
And for that matter,
So-
any interstitial lung process can
Yes,
cause
yes,
some
yes.
mediastinal adenopathy. I think in the setting of the weight loss is where the concern was, which is
Okay.
why, either bronchoscopically or CT guided sampling of that tissue may be useful.
Sure.
And just, this may seem stupid, but has a retroviral serology been done?
Not really. Not really. I've not done it.
Oh, I think we should.
Okay.
I think it would be a good idea to do it before the procedure,
Yeah,
Shobha. That would be the
definitely,
best way to
definitely.
put it across.
Yeah.
Yeah. Okay. Today we are very fast. We'll move to fourth case. Yeah, Prakhar, all yours.
Okay, ma'am. Good evening, everyone. Am I audible?
Yep.
Okay, so I'll share my screen. So we have a 35-year-old young male who is a medical representative by occupation and had been a former smoker. He is a known case of ulcerative colitis since November 2020, had COVID-19 in 21. However, it was mild. And now he has presented to us with shortness of breath since 1 year and dry cough since 3 months. So shortness of breath was initially grade 1, progressed to grade 3 over the last 3 months. Dry cough is since 3 months only. Among drug exposure, we do have mesalazine exposure of 1200 mg BD for ulcerative colitis since 2020, which he discontinued in July 24. And he also had some exposure to air cooler, no other exposure history, no connective tissue symptoms, and no systemic symptoms in terms of fever, hemoptysis, or chest pain.
Okay.
His SpO2 on room air was 95%, rest of the vitals were stable, had grade 3 clubbing, and respiratory system showed bilateral basilar fine crepitations. Musculoskeletal just had some left shoulder limitation of motion for which an ortho review was advised, and it was told that it might be frozen shoulder, nothing specific. Gastro review has been done now, and there is no abdominal complaints right now. And among the labs, the critical things were that his hemoglobin was 8.9, rest everything was okay, and CRP was elevated, 87.4, ANA, ENA anchor profile, everything normal, echo as well.
Okay.
So I think we can discuss the BAL and biopsy post CT discussion.
Yep. No
Or
problem.
I can tell.
So when did he come to you, Prakhar?
In November 24.
And July he has stopped these drugs.
Yes, ma'am.
And before July, how long he received that?
Since 2020. So almost three and a half,
Three.
4. Yeah,
Okay.
3.5 years.
Okay. This is a little interesting case. This is the chest radiograph, and when we look at the mediastinum, we've got a few things to notice in here. One of the things that we can start to see are these calcified nodules. There are all these small nodules in the lung parenchyma. Some of these are calcified, as you can see. And as we go up into the mediastinum, we start to see again lymph nodes. That's a big subcarinal lymph node. There is a reasonable size iotopulmonary lymph node, right paratracheal lymph node, and then some in along the bilateral hyla also we are seeing these lymph nodes. At the apices, there is some pleural thickening, bilateral pleural thickening with mild areas of pleural calcification. You can see these tiny small areas of pleural calcification. There is no pleural plaques as such. And we see the lung parenchyma, quite interesting changes. We are seeing these extensive areas of interlobular septal thickening. We are seeing a lot of fissural nodularity. We are seeing lots of these septa which have got nodularity all along. And then we are seeing these paraseptal cystic changes throughout the lung. Where as we go up into the upper lobes, it is much more pronounced. You can see these paraseptal cysts. And as we come to the mid and lower zones, there is a little bit of sparing of the subpleural aspect posteriorly in the mid and lower zones, but there are extensive changes all the way down to the lung bases bilaterally. So when we are looking at this has a very wide differential diagnosis, especially with a nodules which are getting calcified. So first thing we were thinking, is there a exposure for a pneumoconiosis kind of an aspect? That was something we were considering. Another differential is to look at sarcoid in this patient with a lot of fissural nodularity, with a lot of septal thickening. Not very typical again, but lymph nodes and everything put together would make sarcoid a good differential diagnosis to consider. Is he a smoker? Do we know?
Yes.
He is a smoker. Okay, so the
He-
paraseptal emphysema is kind of explained by that. Apart from these two, out of the box would be something else that we'll have to think and doesn't fit pulmonary alveolar microlithiasis fully. We would like to see more ground glass nodules. Again, that calcification is not very typical of that. HP is a possibility again with nodular nodule getting calcified is less likely. So the top two for me would be sarcoid. Second would be pneumoconiosis, but I do understand there doesn't seem to be any work-related exposure in here.
True, sir. So he did not have any other occupational histories. So occupation-wise, sarcoidosis was again our first differential diagnosis as well. And ma'am, can we share the slides first?
Yeah. I just wanted to ask, Vimalda sir, you happen to see the CT scan which he sent just now, just
No,
few
I
hours
could
before?
not. I could
Okay,
not
okay.
download it.
Although it's
Okay.
quite similar to this one, ma'am.
Okay, no changes. Fine.
So in the pulmonary function testing,
You want the biopsy? Yeah.
Sure, ma'am. So we went ahead with a BAL and a biopsy. BAL was mostly negative. The differential of the cytology was with 240 cells and 80% lymphocytic. CD4, CD8 came out to be just about 0.2. Cryo by TBLB was done. Now it showed that we do not have the histopathology images that the sample was sent outside actually. So we just have the report. We discussed with the pathologist although, and they stayed with this diagnosis that the lung parenchyma is showing cholesterol left and giant cell formation with focal lymphoid aggregates and intraluminal macrophages, occasional asteroid body formation, and focal osseous metaplasia. And in the biopsy sample, they could not find any interstitial fibrosis and gave us a differential diagnosis of first HP and secondary was secondary to ulcerative colitis. Spirometry again had a restrictive pattern. The LCO showed a significant drop to just about 28%. However, on 6-minute walk distance test, he did not have a significant desaturation and could walk around 306 meters of distance. Body pleth again was more sober. Okay. So in summary, he's a 35-year-old medical representative, and I think we can move to the questions.
What is the date of the lung function, Prakash?
Sir, it was done in November. Do not know exactly the date. Somewhere around 15th November, I suppose, sir.
And we don't have any previous lung function, right?
No, sir. No, sir.
Yep. Okay.
So I think the question 1 has been already answered by Vimalraj, sir. How do we classify this radiology? This question arose because on biopsy, we could not find any interstitial fibrosis. However, the CT was quite suggestive of it. The next question comes down to, could it be mesalazine-induced HP as per the differential given by the pathologist? Or it's something else, non-drug related IID? And the third one is, if it is drug related, what would be our treatment strategy in such a case?
That was the reason I asked question that whether the CT scan was showing any improvement, because it is almost more than 6 to 8 months, and if the radiology is not clearing, then unlikely related to drug other than irreversible changes, like sometimes it happens in bleomycin or something.
With us, he has just been around from November, ma'am. So we haven't initiated him on any treatment yet.
Yeah.
Can I comment?
Yeah,
Yes,
but
sir.
it could still persist, I think, Asmita, even after withdrawal of the drug sometimes. So
Yes, sir.
I'm not sure whether we can 100% say this is not drug related. Yeah, Prahlad?
He's a young boy, 35, smoker, and he had ulcerative colitis. We don't know. Really, ulcerative colitis was diagnosed by colonoscopic biopsy.
Yes, sir. It was
diagnosed.
as per the reports.
Yeah. And I feel probably we have not got interstitial lung disease because maybe we have not got a correct area of biopsy that time. That is a possibility. But this whole picture looks more favor like a sarcoid, actually, chronic sarcoid. And HP, all features, I don't think so. They are like in this, at least on HRCT, everything is there. We should have done a lymph node biopsy also here because there were multiple lymph nodes. Probably that may have given some clue also in getting a diagnosis. This is what I feel. So, though we have not got a sarcoid diagnosis, it does favors more as a sarcoid. What else we can do? I think we should get a PET scan done for him, okay, and try to find out is there any activity elsewhere in the body, okay, and probably that may help us in targeting a new more biopsy. But this is not a conclusive diagnosis, I feel. Even ulcerative colitis will not give such type of a interstitial lung disease. We generally get some sort of a non-specific interstitial pneumonia, or may get some fibrotic NSIP, or that also you should have a chronic ulcerative colitis to give this diagnosis. This looks like a primary lung disease, okay, something which is lymphangitis carcinomatosis is very close diagnosis for the sarcoid like this, but there are no so many septal thickenings are not there. There are significant subpleural nodules, but with lymph nodes and nodularity, with the way patient he has a presentation, I think we are not catching the diagnosis on this biopsy. We are missing something.
The only thing is that if this was sarcoid, we should have picked up a lot of granulomas there, no, Prahlad? And also a higher CD4, CD8 ratio should have also been higher. It was just 0.2. So there's some, sarcoid often gives you.
Vimal, what is your radiological opinion?
And even with so much of granulomatous, if we are thinking in terms of so much of nodularity, our serum is just about 26. I understand that it's not 100% specific, but usually we find elevated.
Yeah,
Please
the ACE
scans
too.
the
Yeah,
granulomas.
yeah.
Yes, sir.
ACE is not that specific,
True, sir.
Prakar. We're using it less and less often nowadays for both diagnosis and monitoring. But I agree with you. Yes, sometimes the
But the
levels
burden of
can.
granulomas, if we are suspecting, then possibly.
Yeah.
Plus,
Yes.
one question to the pathologist: could we utilize this finding of asteroid bodies in favor of sarcoid somehow in this case?
No. Asteroid bodies can be found
Again,
in
non-specific.
sarcoid as well as in HP
True.
and in other granulomatous lung diseases. But according to I have not seen the images, nor did I see the slides. But according to the report, what I think is even this IBD, inflammatory bowel disease or ulcerative colitis, whatever, can cause granulomas, and these may mimic hypersensitivity pneumonitis. And the focal lymphoid aggregate also, which they have mentioned, might go in favor of this IBD.
ID,
I would
UC.
Inflammatory bowel disease. Yes,
Okay.
you see.
Okay.
Yeah.
So I would trust the first pathologist who made a diagnosis of ulcerative colitis. I assume it was in the background of a clinical picture that fits.
Yes, sir.
So, when you have one diagnosis, is there a need to bring in a second diagnosis? We know that both ulcerative colitis as well as the treatment mesalazine can cause this kind of disturbance, can cause an interstitial lung disease. It is very tempting to think of sarcoid, and I believe there are a few cases of sarcoid and ulcerative colitis overlapping. But in the principle of parsimony in your diagnosis, I would stick to ulcerative colitis, drug-induced. I completely agree with Dr. Prahlad Desai's suggestion of doing a PET. I think that's a very valuable thing. And that will give us a second chance at biopsying something which is more accessible. So I would do that first. And I think two things can be done. One, he's been off mesalazine for a few months. Is it worth re-challenging him and seeing if he has an acute worsening? He's been off it for 5 months. It's a kind of double-edged weapon, but will tell us whether it is due to the drug or not. Obviously, it'll have to be discussed carefully with him and say, we'll give you one dose and see if your lung function improves, your DLCO comes down, your 6-minute walk distance comes down. But that is a double-edged weapon. So I think first a PET scan, biopsy, and then lacking anything else, a re-challenge and see what happens.
So
Yeah, I'd
Shadi,
like to add that mesalazine, it's been described in the pneumotox that I just had a look, is causing ILD with granulomas.
Yeah.
So it is being
Exactly.
described in the pneumotox. So
Yep.
I think that this pattern could, we as previously kind of mentioned that diagnosed ulcerative colitis and then mesalazine-induced ILDs, it has a kind of a good argument here. And I'm not sure whether we could do a follow-up CT scan and then see actually whether these things are getting better sequentially. Because that it has been discontinued for about now 5 months, and you have been started steroids as well. Is he
No,
on
he
any
didn't
steroids at
start.
the moment?
no, sir, he hasn't been started on steroid yet.
No, he's not on
Okay.
steroids as yet. Why did he stop mesalazine, Prakar?
So he just got better. Even now, when we got a gastro review, he's abdomen-wise, he's having no complaints right now.
Okay.
And secondarily, we have just repeated CT scan, which I shared with ma'am, at an approximate gap of 2 months. Very
Oh.
simple. No improvement, nothing deteriorating.
Okay.
Drug-induced,
This
it
means
can
that over
show
the
some
7 months.
foamy change.
Sorry. Yes, ma'am.
Drug-induced ILDs, they show foamy change in the alveolar epithelial cells, and also there will be foamy macrophages in case of drug-induced ILDs.
And
Yeah,
also
trial of steroids and
eosinophilic infiltrates, I guess, Sharda?
Yeah. Few eosinophilic infiltrates, but some cause eosinophilic infiltrates, some drugs, and some drugs they show this foamy change in the alveolar pneumocytes.
But drug-induced ILD will never cause this calcification kind of thing, sir, Vimalraj sir?
I think you can get any presentation in drug-induced ILD.
That is the fact. The one thing which we have seen very commonly with drug-induced ILD is some form of airway disease with some air trapping being there, which I have not seen in this case.
Yeah.
which is something which kind of is like a thumb rule. We like to see it, but in this case, we've not seen it. Doesn't mean we can exclude it, but that is something to help with.
Mithun, you unmuted. Did you want to say anything?
No, no. The CRP level is pretty high, no? What about?
Yes, sir.
I think we should go ahead with a PET scan. We should look for other areas of any involvement and take a biopsy. I think diagnosis is not yet clear. Very high CRP. If you don't treat it for some time, I think patient will likely to worsen.
So as a crux, what are we thinking in terms of?
I guess the PET
Quite an-
scan Prakhar is being advised because of his age. Because I see three
no.
people advising a PET CT, and which I didn't think of. But I'm just assuming it's the age. Am I right, Murli, Prahlad, or?
No, sarcoidosis or no. If you have a sarcoidosis in some other areas, you can take a biopsy from that area, or that may be
Fair enough. Yeah. Fair enough.
He's a young boy, no?
Yeah, he's a young guy.
35,
I was
35.
thinking of his age, yeah, as you don't want to miss something elsewhere. But ulcerative colitis, sarcoid, I don't know whether there'll be different patterns, but you may get a easier biopsiable site. Yeah.
IBD association with ILD is very, very rare, no? Actually, we
No,
don't
it
see.
is there. We
It
do
is
see.
there.
We do
Is there.
see. IBD association is there. Misalazine is also very much there.
Yeah.
So
This is second case. Now,
yeah.
few MDM before I discussed, I will bring up after 6 months of stopping mesalazine. That is what. So mesalazine, that time I came to know first time, but that time also Murli Mohan sir told that ulcerative colitis itself can cause ILD in some cases. So not always related to drug. So Prakhar, they all want a repeat biopsy and PET. PET.
In case, okay, now.
Yeah, PET
Correct.
plus or minus repeat biopsy rather than that way. Yeah.
Would it
And
be
then
feasible to go ahead with a repeat lung biopsy post-PET, maybe? But here, because the cost is some concern, so maybe most probably the patient won't or might not be able to go ahead with a PET scan. It's not available in-house. We have to send the patients to Delhi or to Meerut, actually.
Okay.
We will still, but in case it's not done, would it be reasonable enough to go ahead with a EVAS and a repeat lung biopsy?
no, we can do CT chest, CT abdomen. What do you say? Right?
Yeah,
Yes.
No,
If PET is not available, you go out with CT abdomen and CT chest.
at least to
If
screen.
PET is not available, then and the CT abdomen may not have an addition. He doesn't have any abdominal symptoms now.
Because,
The best will be to spend money on EBUS biopsy along with repeat lung biopsy.
Okay.
I would agree.
can
I
pick
think
up the diagnosis.
previous
more
CT
specific.
already covered the upper abdominal cuts and did not show
Sure.
granulomatous.
Yeah, agreed.
Even if it is ulcerative colitis induced ILD, biopsy can show the specific features. It can give the diagnosis.
I think biopsy clearly is the way to go if he cannot afford a PET. If a PET will give us a simpler area, maybe a low cost biopsy. So that's the advantage of a PET first.
Sure, sir. Great, right. Thank you so much.
Okay, I'll go to the last case of Rajan sir.
Thank you. Bye-bye.
So this is a lady who threw out her earlier reports I think with stress and frustration, but she followed up after a couple of 2 or 3 years now, and she stays in Mumbai, not married, antenatal massage therapist. That's her profession. No comorbidity. She came and told me, and I had seen her mother and her father with ILD. So her complaint was, and I wanted to follow up her, and she has 2 siblings very closely. The siblings do their lung function, and but as you can see, the family history is really quite worrying. And so when she came with an abnormal CT a few years ago, I said, I need you to follow up regularly because I don't know what your CT is really looking like. We talked to her about a biopsy, and I think that's why she disappeared for the last 3 years. Occasional cough doesn't affect her work or sleep. However, she has needed 2 1-week breaks from work in the last 6 months, which is why she came into clinic. And we did her autoimmune workup. Pooja is on the line from ICMR. They ran the tests, and row 52 was mildly positive. And her mother was my oldest patient in the family. 2002 to 2009, we could only give her mother steroids. And then her father was a patient from 2008 to 2016. He received pirfenidone for 5 years before his death because pirfenidone became available in India in 2010. So from 11 to 16, he received her. So you can clearly see the father lived a little, not little longer, but he pulled on at an older age. So this is a lung function I have today of hers, which is not bad, as you can see. It's vital capacity is good. DLCO is low, 39.7. Ratio is, so it's very mild obstruction there, mild to moderate obstruction actually. No reversibility. DLCO 39.7, KCO 63%, and a 6-minute walk, 440 meters. From 97, she goes to 94. And this was the myositis profile, which showed this slightly positive row 52, which I don't really know how much significance to give to that. And then maybe we can see her scans and get Mithun. And yeah, Mithun, any input on that blot?
No, sir.
Nothing
Nothing
major there.
happened.
Yeah. So, and she has no symptoms of autoimmune disease. And these are her scans. Yeah.
So we're starting off with her old scan, and this scan is dating back to 2021. When we look at the mediastinum, the only thing we are seeing is that the esophagus is quite patulous along the entire length for her, and all the way down with a small hiatus hernia in the end. When we look at the lung parenchyma, what we can see, I'll start at the top, are these irregular cystic spaces which are seen towards the periphery in the lungs bilaterally, and then few isolated cysts are seen in the lungs bilaterally. And then when we come into the left lower lobe, that is where we are seeing some areas of interstitial thickening, traction, dilatation of bronchi, but again, few clusters of cysts that we can see. Focal areas of fibrosis as such. Not much of nodules, no mass lesion, no honeycombing at this stage. And there was no air trapping on expiratory imaging. Now, if we fast forward it to now, which is 2025, I'll just show you this scan first. The esophagus continues to be dilated. And when we look at the pulmonary artery is normal, not much in terms of lymph nodes, small lymph nodes. These are not significant. But when we look at the lung parenchyma, the disease has progressed. There has been progression. There are more of these cystic spaces in the upper lobes which are coalescing together. And as we come down, the number of cysts have increased throughout. Focal areas of fibrosis in the right middle lobe is new with patchy ground glass opacities. And the same thing in the left lower lobe has also progressed as we go down. And bilateral lower lobe has also progressed. So overall, there has been progression of disease. This is got a component of fibrotic ILD now with a background of other cystic changes. I don't think this is a cystic lung disease as such. The upper lobe, these coalescing cysts, I would be thinking more in terms of a connective tissue disease related interstitial lung disease, which has progressed over a period of 4 years.
Yeah. So my questions, Asmita, if you could.
Yeah, I will.
I really don't know how to class. First of all, this is a difficult patient because she's just come again for follow-up, no treatment. has not done any tests in between. We can't even get a whole lung function to just see how much she's dropped, but she's probably has dropped because the CT has progressed. What is our working diagnosis here with such a family history? Should I push for a lung biopsy? And her brother and sister I realize she has progressed, as you rightly said, Vimal. And so her brother is going to get his lung function test done. But I think, keeping all this in mind, I was keen to do a lung biopsy, but with the strong genetic component, it is usually advised not to do a biopsy. So I don't know what your thoughts are, and maybe Pooja's thoughts on what have we done the genetic testing, Pooja, on her telomere and surfactant mutations?
No, sir, not yet.
Not yet.
But we can do.
Yeah, I think I'll do that. Yeah, but any other thoughts here, Prahlad?
Yeah, I think her job is antenatal massage. Okay.
That's right.
So this antenatal massage, I don't know what sort of a massage. Probably they must be using a lot of oils,
Aromatic oils.
aromatic
Aromatic oils.
oils.
Yeah.
So definitely, she must be inhaling also some of aromatic
Yes.
oils,
Yes.
and she has an airway disease. That's very important because
Yes.
it's an obstruction. Okay.
Yes.
And the small cyst formations can be one of the reasons for small airway disease, probably. She may be having. And component of some septal thickening at the bases, etc., which is there indicating some fibrosis component. Considering her age of 54 and her parents died, at what age they died, but actually.
I can't be, but I think her dad was about 70 and her mother probably around 60, early 60s.
So she, in last 4 5 years, the HRCT is progress. Probably she's going to give more emphysematous changes and cystic changes she will develop.
Yeah.
And of course, fibrosis also. I think we are dealing with some sort of an inhalation, chronic inhalation related lung disease, maybe because of airway plus lung component. We don't know that some of the oils, etc., may also form cysts inside. Okay, when we inhale. So,
But then the family history is not telling with that, right?
no, the family history is supporting that. No, that is adding to her occupational issues. So probably
Okay.
she is going to develop fibrosis, no question about it, because there is definitely increase in the septal thickening compared to the previous scan.
So how would you treat her? With antifibrotics or if you're to give her or suggest a treatment, if she refuses biopsy, which I think she will, and meet her next week.
We should treat
But
her airway disease with inhalers, okay,
right.
with a small airway,
Yeah.
probably something like which will have little better penetration inside, and we should start upfront antifibrotic. That's what I feel, because she will develop fibrosis.
Progressive disease. Yeah. Progressive
Family
fibrosis.
history,
No,
I
she's
don't think
progressed as
any
per
other.
Vimal. She has progressed.
Yeah.
And Bhavin also mentioned when he saw the scan, she has progressed. And therefore, giving her antifibrotics would be lifelong, and I'll have to counsel her about that. Yeah.
We
I
cannot give
think
immunosuppressants to her because of her family history, etc., and all that. We don't know telomerase whether she will develop toxicity due to the drugs.
yeah,
She has to
because
also.
even when I look at the mother also lived for 7 years, but only with steroids. And maybe I can get Bhavin to pull up their scans because all the scans were done with Bhavin. And the father, however, lived less, but he lived longer. But since the diagnosis, he survived 6 years, unlike the mother. So I think she has been with a diagnosis now for about 4 years, 3 to 4 years, and her lung function is reasonably well preserved as of today.
Just as a thought, sir, this father and mother may not have the same kind of ILD, right? Because
No, it cannot. But I
yeah,
get Prahlad's point that the mother died in 6 to 7 years. The father also got antifibrotics for 5 years. So maybe steroids was worsening these patients. That's possible, both of these patients, because the father lived for a longer time on antifibrotics. And yeah, because and maybe telomere length testing, I don't know, when will we be able to do that, Pooja, you think, for her?
So we have received the kits, but standardization is yet to be done.
Sure. That's what do you think, Prahlad? Do a telomere length also, no, for her?
May give us little more background.
And are there any other features of short telomere syndromes like any liver involvement, cytopenias, and all?
No
And
cytopenias, Amila. No liver involvement, and
also,
Does she has early graying of her hair?
no. In her 20s, no. I asked her about that. She says no.
and do we know the family history beyond the parents? Actually, that is a family tree, full family tree.
I don't. In fact, I want to increasingly do that. That's why I got Pooja on the call. Pooja, do you have it? Have you taken it?
Sir, like just a question, can we do whole exome testing for her?
Yeah, you can.
I
Absolutely.
was thinking to do it like here in house.
Okay. I mean, if it can be done, nothing like it, but I haven't taken that full, what's that family tree called? What do you all call it?
Pedigree.
Pedigree. That should be done actually. It should be done for all our ILD patients. We
Yeah.
don't do it as often as we should.
Because it seems an ideal case to be done since it has family history.
Yeah. I think we should do that. And maybe we could get the films of the father and mother if we can get them from Bhavin's system, if he's kept it, some of these scans for a long time. We may be able to pull it out and discuss this.
Sir, one doubt, sir. These father and mother both are from different genetic backgrounds, no? Then
Yes.
how this genetic thing, or they are common? There is a common exposure to something.
There is
Exactly.
yeah.
So, if two members of the family have ILD, you either look for consanguinity. So I think that's important to check. A
Yeah.
family history, chronic fibrosis, fibrotic liver disease, and a common exposure. A common environment is what they share. So that's something we need to look at. And it need not be the oils, because I'm not very sure the parents have the same kind of exposure to the oils that this lady would have, but they would have other common exposures. So that's important to check out. Vimal, I wanted to ask, is this more likely to be cystic, or some of them look almost emphysematous? And given the, lung functions that suggest obstruction, would you agree that some of them look emphysematous rather than cystic?
Yeah, everything in the upper lobes is all emphysematous. They are coalescing and they are not cysts. The cysts are just a byproduct. So it's not a cystic lung disease. It's interstitial lung disease, which has an airway component associated with that.
So that's the only other thing that came to mind, whether we should also be looking at alpha-1 antitrypsin in a younger person.
Mm-hmm.
And I completely agree with Pooja. I think a whole exome sequencing, especially if you don't have the telomere length, I think is a better way to go about it. So I would do in somebody with what may be a hereditary ILD, doing a whole exome sequencing, I think is a very good idea.
We do that. Yeah, we could do that. I will just tell her that and, tell her siblings. Her siblings are more worried about her. She has a younger sister and elder brother, I think, right? Or younger brother. I think she is the oldest. So younger brother and a younger sister. And
some of these genetic things, occur earlier and earlier with each generation.
Correct.
So
I'm thinking maybe we do the scans of the siblings also. I'm just thinking, what do you think, Vimal? Should we just scan the siblings also?
Absolutely. I think we should.
Yeah. I will tell them.
So are you not thinking about lamb and bird hog breeding something?
No, it's predominantly not a cystic lung disease. I think it's just a byproduct.
So that's what Vimal was saying. The cysts don't seem to be more, Sharda, byproduct of that little emphysematous change there. Airway disease is there. And in fact, the first time round, I also thought of cystic lung disease, thought of getting a biopsy done. I'm just wondering whether we should do a VEGF-D level also then, just to get that out of the way. Pooja, can you run that also, VEGF-D on her?
Yes, sir. Yes, sure.
Perfect.
So she can afford for all this, huh? Because
No,
even
that's
my
why we have
patients
Pooja.
cannot.
That's why we have Pooja on the call.
You are just adding because whole exome sequencing that even after listening that itself, I was like, okay, patient will afford that kind of,
No,
because we do
that
limited screening and all.
that's
Yeah.
one of the reasons myself and now hopefully Prahlad also soon are
If she would
working with
have
the.
afford, then maybe massaging would have been the best profession.
Yeah, I was also like, how come my patients cannot afford whole exam and all? Na, I will be thinking like, how will I send? Okay.
No.
Then
So
it can be a familial IPF sort of a
yeah.
thing.
So
Familial
familial
IPF.
IPF, actually, both her parents didn't have a classical IPF CT. I could distinctly remember her father had more of an NSIP pattern. And so I thought this will turn out connective tissue disease, but the whole workup so far has been negative. And she's remained so stable. She's saying, what's all the fuss about? It was her brother who actually dragged her to the clinic, and he said, look, we had an abnormality 4 years ago. I want you to see her now, And he's going for his lung function, but as Vimal said, I'll get his CT also done.
Yes,
I will
Murli sir.
follow this up maybe to pick Athol's brains on it, Athol and
Oh,
Bhavin's
yeah.
brains on it also
We'll
the next
bring
time.
all the CT together. Yeah.
Yeah.
Murliman sir, you were saying something. Yes.
No. I exactly what I would love to hear Athol's views on these. And we've missed him today. You should tell him that.
Yeah. No, that you will not say, na? Rajan sir said like that. Yeah. Because that makes him happy. Okay. I think, are we done? Anything
Okay.
else? Yeah.
Thank you.
Okay.
I'm
Thank
actually
you.
grateful. I just got into Chennai in the nick of time with 5 minutes to go, and I was able to log in. So
No, today we are relatively early because last time we finished by 6:45 or 7 o'clock, and it was a really marathon kind of MDM. Today we are easy, and thank you so much. I think because we all were on time, everybody started discussing. Very effective discussion. Thank you so much, Prakhar, Shobha Madam, and Rajan sir. We
Thank you.
all enjoyed the discussion. Thank you, Rajan sir and
Thank you.
Vimal Raj sir.
thank you, Dr.
Thank you.
Smita most.
Thank you.
Thank
Thank
you,
you very
Vimal.
much.
Thank you, Sharda. And
And
Thank you all.
Prahlad Prabhu Desai sir. Thank you so
Thank
much,
you.
and thank you
Thank
all
you,
the delegates.
Pooja. Pooja, offer your. I say, are we
Yes,
offline now?
Pooja. Thank you
Are
so
we
much.
offline now?
Not yet. Thank you all the delegates, and our next meeting will be on 31st of this month. Manish, can you make us on offline?
Thank you.
Yep.
Good evening.
Good evening.